Dear colleagues, welcome to the European Heart Journal Dialogue. On behalf of the Editor-in-Chief, Filippo Crea, and my Associate Editor, Professor Giovanna Liuzzo, I'd like to welcome you to discuss an interesting topic related to conflicting evidence on the efficacy and safety of colchicine for cardiovascular disease prevention. We are lucky to have some outstanding speakers this afternoon. Sanjit Jolly, who is the principal investigator of the CLEAR-Colchicine trial, and François Roubille and Massimo Imazio, who are expert in the field and have contributed importantly to the field. As you know, there has been conflicting results published quite recently from the CLEAR-Colchicine trial that we will discuss in some detail with its principal investigator. And the questions we would like to address are really, firstly, is there a plausible explanation for the apparent discrepancy between the CLEAR results and those of earlier trials of colchicine? And what is the totality of the evidence from randomized clinical trials of colchicine suggesting about its efficacy in preventing cardiovascular disease? Thirdly, do treatment guidelines need to be revised in light of the CLEAR results? And finally, where is the field of anti-inflammatory drug therapy going after CLEAR-Colchicine? Of course, we will entertain additional questions, not only by the discussants, the invited discussants, but also from you, the online participants. So I will now ask Giovanna Liuzzo to introduce our first speaker, Professor Sanjit Jolly.
Thank you, Carlo. Thank you to everybody to being here with us to this inspiring dialogue on colchicine. It's my pleasure to introduce Professor Sanjit Jolly, Professor of Medicine. He's a clinical trialist and an interventional cardiologist at McMaster University. He has led several important international randomized trials in interventional cardiology, like the total, with more than 10,000 patients enrolled, the RIVAL, and so on. Besides his specialty in internal medicine, cardiologist, and interventional cardiologist, he also completed a master in research methodology with Mehta and Yusuf at McMaster University. So it's really a very important, relevant trialist. And he is the global principal investigator for the CLEAR Oasis 9 trial. So it's my pleasure to ask you, Sanjit, if you like to summarize for us the design and the main findings of the CLEAR-Colchicine trial. Thank you.
It's my pleasure, and it's my pleasure to be able to be here at the European Heart Journal discussion. This was a trial, I think it's important to note, that started prior to the results of the other colchicine trials. So this was really the genesis of this trial. I can tell you, I was sitting in my office reading a paper journal, and who reads paper journals anymore? But I read Jack and read the Liuzzo 1 trial by Mark Nydorf. And then there's this single center trial with hundreds of patients showing a 70% reduction in cardiovascular events with colchicine. Wow, this is a wonder drug. We need to test this drug in a clinical trial. So that was the genesis. And we essentially applied for grants. Nobody's going to fund this trial from a pharmaceutical company. And we randomized 7,000 patients over a period of like 4.5 years. And we started off with ST elevation MI, and then we expanded to non-STEMI. And our hypothesis is go where the money is. You know, in CAD, most of the money is in acute patients because they have the most events. And even if you look at many results of trials, the post-MI population, so even in chronic CAD, patients who had a prior MI tend to have higher event rates, and that's who tend to be responsive to interventions. And so that's where we went. And it was, colchicine was one of these drugs where there was a group of people who believed in it, but actually, for the most part, the community was very happy to randomize. And then we also did a 2x2 factorial design with spironolactone compared to placebo. And even out, while we're conducting the trial, the Colcott trial came out, Liuzzo 2 trial came out, and we surveyed investigators. Do you feel there's still equipoise? And for the most part, investigators were not using colchicine routinely, and they said they felt there was still equipoise. And then we unblinded, and we were very surprised to see the results. We saw no effect for the primary outcome, CV death, MI, stroke, or ischemia-driven revasc, and no effect on any of the individual components. And we had pre-specified on-treatment analysis, just worried that, perhaps there may be issues, but the on-treatment analysis was completely neutral. And I think one of the interesting facts is that this trial started off as initially a pericarditis regimen where we used colchicine 0.5 milligrams twice daily for the first 3 months in those over 70 kilograms. And then once the other trials came out, we actually amended the protocol and went to once daily because it's just better tolerated. And this trial was run during the pandemic, but I don't believe the pandemic made this trial completely negative. And generally, you reduce your event rates, but our event rates are what we had expected.
Okay, so I have a question for you. You said that the drug doses was changed at some point because the other trial was coming out, and you see that low dose, less events that make people don't tolerate the drug. So you made these changes. You also made other change into the protocol during this period because of the pandemic or not?
We increased our sample size from 4 to 7,000. We also added ischemia-driven revasc as a part of the primary outcome.
Okay, so you made
and that was consistent with the prior trials.
Okay.
And this was all done in a blinded fashion.
Okay. For sure, this is the most largest trial exploring this hypothesis. So 7,000 patients randomized, 3-year follow-up. So what you would like to say about this in comparison with the other trials that in the meantime were coming out? The Liuzzo 2 and the Colcott trial.
I think in terms of we size a trial based on number of events, right? Not the number of patients. So it's important to note that the CLEAR trial had more than 600 outcome events, more than twice the number of outcome events as the Colcott trial. So in terms of acute coronary syndrome, this is substantially more evidence. In terms of chronic CAD, we had more outcome events than Liuzzo 2, but it is somewhat of a different population. I think the other thing that's important is this is the main question: why are the results of the trials different? And I can tell you, an anecdote is that we unblinded Salim Youssef, who's the chief of our research institute, and he sat there and said, "This makes no sense." He said, "The statistician, did you check results? Can you check it again? Has it been done in duplicate?" And he was raising his voice at this point. And if you know Salim, you know him well, and you're laughing, and Peter's laughing and then John Eichelboom, who was in the room, and John, in his Australian accent, says, yes, the statisticians have checked it twice. Yes, this is the result. He said to me, "I want to tell you 2 things. First thing is the Liuzzo 1 trial, there were issues in terms of the randomization." And Salim says, "What do you mean there were issues in terms of randomization?" And he says, "If you read the JACC paper carefully," and he, showed us, there is a statement in the JACC paper saying that patients who stop study drug could be replaced with new patients that were compliant. And what does that mean? That means that patients who stopped study drug for compliance issues were then replaced. And so all of a sudden, the inspiration for our trial, the kind of motivation, it likely overestimated treatment effect. And then John Eckelboom pointed out another strange fact. He said, I'll tell you, Lodoco 2 was run as two separate trial databases with the same protocol. And there were one was run in Australia, and one was run in the Netherlands. And the Netherlands group worked with us and were recruited a fair bit to the CLEAR trial. The Australian group was Mark Nidoff, the same fellow that ran Lodoco 1. And he said at the end of the trial, we could not understand the huge difference in effect. In Australia, colchicine worked amazing. It was a wonder drug. In the Netherlands, colchicine did not work. And we tested colchicine levels in both countries. We could not figure out. But he says, we always wondered why that was the case. Was this a real finding? Was this false? Was this the play of chance? And so, the Dutch were in our trial. We did have Australian centers as well, but the recruitment from Australia was fairly modest. But there are some outstanding questions. And I think at the end of the day, if this was a new drug, right, this was a new statin or new, some sort of drug therapy, this would be a trial of 20,000 patients. Even our trial would relatively be underpowered, for the FDA or EMEA in terms of new drug submission.
Okay. So, Carlo, would you like to introduce the other guests?
Yes. So our invited discussants are Professor François Roubille, who is responsible for the medical team on heart failure at the University Hospital of Montpellier in France. He has had a 3-4 year experience at the Montreal Heart Institute, where he studied inflammation and ischemia reperfusion in the heart, but also inflammation and endothelial dysfunction and proliferation. And the second invited speaker is Professor Massimo Imazio, who is Professor of Cardiology at the University of Udine in Italy, and also Director of the Cardiology Unit at the Santa Maria della Misericordia Hospital. He's chairperson-elect of the European Working Group on Myocardial and Pericardial Diseases and fellow of the Heart Failure Association of the European Society of Cardiology. So welcome, François and Massimo. Who would like to start questioning Sanjit or adding other comments to the discussion?
Thank you for the invitation. I would like to start because I have a very bad connection, if Massimo agrees. First of all, congratulations for this study, raising lots of questions, as you said. I would add that many meta-analyses have been submitted. This is interesting because this could support or not the effects of
we are losing him.
Which remains a bone of contention, as you said. The European Heart Journal, we've shown the effect remains interesting when you are merging CLEAR with Colcot and Lodoco 2 mainly, and COPS 2, suggesting that there could be an effect. So my first question would be, do you think that pandemics, you answered a bit, but a pandemic with lots of withdrawal of drugs, first of all, and secondly, the events very fewer after the pandemic than before, it could be enough to explain such discrepancies. I understand that you did it. It's interesting to discuss.
Okay, so the question is the meta-analysis. So we do have a meta-analysis, but I don't think I can discuss the meta-analysis because it's at the European Heart Journal, or can I, Carlo?
Yes, you can. You can.
Okay.
I checked with the editor-in-chief, and
Okay.
you are both allowed to, because you both have accepted meta-analysis in the same journal.
Okay. So, our meta-analysis suggests a small treatment effect when you combine all the trials. There, in terms of a broad composite, including ischemia-driven revasc, stroke, MI, cardiovascular death, There was some concern initially of a harm for non-CV death. That is no longer the case. But there is a downside in terms of GI side effects. There's a significant risk increased, and the number needed to treat is actually fairly high. So, our conclusion of a meta-analysis is that there are some benefits potentially, and there are some downsides to it. And we can see your screen. I don't know whoever's working away. And I think the importance there is when you have the largest trial conflicting prior smaller trials, and you have a meta-analysis that shows a benefit, I'm always a little bit cautious in the interpretation there. And some examples would be magnesium and acute MI. And so, I think that while there's a potential treatment benefit that may be quite modest, there's some side effects. And I think we are still farther ahead than we were before the trial. And I think, from clinically, I would like more data. And we do have a number of trials that are ongoing. We have a PAD trial that our group is conducting, colchicine. So we'll have further data in terms of the effectiveness of colchicine in vascular disease.
Can I
totally agree. We were missing
the pandemic question. Should I answer that? Okay.
Yeah, the pandemic question.
Yeah. So, there have been there's opinion pieces written stating that CLEAR was negative because of the pandemic. And I think generally the pandemic reduced event rates, and as a result, trials were underpowered. And occasionally, around heart failure, there may have been noise. I think it's important that heart failure wasn't part of the primary outcome for CLEAR. The second thing is the trial spanned the pandemic, ran afterwards and ran before. Third, there was no statistically significant interaction by the pandemic. And fourth, by increasing the length of enrollment, increasing the number of patients, we compensated for the pandemic. So we needed a 9% control event rate, and we had an event rate above 9%. We had the required number of events. And the way pandemic screws with things or causes problems is that if you have angina and have a recurrent, narrowing, you don't come back for PCI. But our revasc rate was what we expected within the trial. We had the required number of events. And while there was the point estimate was below 1 pre-pandemic, slightly above during the pandemic, and still, not beneficial post-pandemic. If it was all the pandemic, we should see a benefit post-pandemic as well as pre-pandemic. We didn't see that. And particularly if it was an issue of compliance, we should see the on-treatment analysis being positive, or at least close to positive. So most of the trials that were affected by the pandemic missed their significance by a small amount, and there was a clear trend. Here, we did not see that at all. So I would have been the first one to say it's the pandemic if our p-value was 0.06, 0.07, and our on-treatment analysis was positive. I wanted this trial to be positive. But as a scientist, I have to say, unfortunately, when we look at our data, that doesn't look like it's the case.
May I ask you something about this? What do you think about the timing of the treatment? Because in the CLEAR, the treatment was very early, within 24 hours after the primary PCI or the PCI in general. And in the COLCOT, that I think, François, is the trial that is more similar to the CLEAR, more than the LODOCO-2, of course. The treatment was a little bit later on. So do you think that this window is like in your case, the treatment was going into the window of dangerous anti-inflammatory treatment for an acute MI, or what do you think about this?
So our inclusion criteria was within 72 hours, not 24 hours. So I think that's important. I think the other important thing is that the COLCOT trial published an analysis, subgroup analysis, showing the greatest benefit in terms of early treatment. So patients who got colchicine randomized within 48 hours had most of the benefit. Patients who got randomized later did not get much benefit. And so when we read that publication and we saw that, We assumed our trial was going to not be positive, but hugely positive if that was true, that early treatment is beneficial. So I think, I don't, and I think the other important thing is this was a long-term treatment trial, right? The maximum was 5 years of therapy. This was not just a 30-day or a 1-year trial. So I don't believe that giving colchicine on 2 days later versus 10 days later or 7 days later makes that much of a difference. We didn't see issues of infarct healing, free wall ruptures. We never saw any concerns, right, that you may see with steroids post-MI. So I don't think it was necessarily a timing issue compared to Colcott, especially because their subgroup analysis suggested early treatment is better.
Okay, thank you. I tell you later on why I'm asking this.
Okay. Surprise.
Massimo, do you want to?
Yes, thank you. First of all, thank you very much for your invitation. First of all, I have to say that I have a potential ideological conflict of interest because I really believe that colchicine works. I was very surprised to see these neutral results. And second, I have to congratulate Professor Jolly for making such a big trial, because without not a sponsored trial, so it is very difficult to do this. And so congratulations, because it's very important. I have three main concerns related to the trial. The first one is relating to the dosing of colchicine. So I am very familiar with the pericarditis dosing, and you selected the pericarditis dosing as you mentioned, but you were aware of the Lodoco trial. So you know that the position of Professor Nidov was just to use low doses, 0.5. So why the selection of a higher dose with potential more problems of compliance? And this was true because you were compelled to change the dose into the trial, and so I think this is a problem. The second concern.
Maybe we can ask one question at a time.
Yes, of course.
Okay, so let me answer this one. So yes, we did know Lodoco 1 in terms of low dose colchicine. That was stable CAD. Our hypothesis is that in acute MI, your CRP, your inflammation is much higher. And you need more potent therapy. And so that was the hypothesis for using a higher dose, particularly in those with higher body weight. We know that dosing of colchicine was effective and as an anti-inflammatory agent in pericarditis and reduced acute inflammation. And so that was the rationale for using this. And this is going back, 7 or 8 years ago. This was early in the colchicine story. And what was interesting is, people point that pre-pandemic there was some treatment benefit. Maybe had we continued with a higher dose, we might have seen more treatment, right? Maybe we saw, but we had pre-specified in our protocol. We were not sure that if the rate of discontinuation related diarrhea was above a certain threshold, that we could potentially go back to once daily. And I think one of the other things is, Colcott and Lodoco use single dose colchicine. So we wanted to provide the lowest possible dose that's effective, and so that's why we switched our dose. But certainly on low dose, if we had seen no efficacy with double dose because there's lots of discontinuation, and lots of efficacy with single dose, because we have, I think there are less than 2,000 patients on the double dose. I think there's about 1,500 patients. So we still have a lot of patients with single dose colchicine. We saw no treatment effect with single dose colchicine, even though it's better tolerated. And the question, and we're still doing analysis, is double dose better than single dose? And that is we're still kind of working it out. What was your second question, Massimo?
Yeah. My second concern is related to patient compliance. So you also clearly underlined it in your paper that adherence to the trial regimen was assessed only for patient reports because pill counts were not possible during the pandemic. I think this is a major flaw that should be considered because we are not confident that patients really take the treatment. So to me, I am a little bit concerned that the trial, so it's very important. The results are intriguing. We need additional evidence, but to me, I'm not confident that these results are reliable, because if you are not sure that the patient took the drug, this is a big problem.
Yeah, and I think that's reasonable. I mean, during the pandemic, it was not possible to measure pill counts. We actually initially were planning to capture pill counts, and we removed it because patients were getting, we were sending the drug to the patients' houses because they couldn't leave. Um, and then once you don't collect pill counts for a portion of the trial, I think we're looking at patient recall. I think the important thing is we did see a biologic effect of colchicine. It did significantly increase diarrhea, and we saw a reduction in CRP. So we do know the drug was biologically active. And I think the other important thing is this was a factorial design with two different drugs. And in terms of spironolactone, that on-treatment analysis was positive, and the colchicine on-treatment analysis was negative. And depending on how you analyze the data, whether you use a competing risk, which was not our primary outcome, but published in New England, but if you look at our standard pre-specified approach, there was a reduction in heart failure with spironolactone. So I'll take it the criticism. We don't know what the compliance truly was because it's self-reported rather than pill counts, but there was a biologic effect in the trial, and there were positive signals from the other portion of the factorial. And we all know spironolactone reduces heart failure. And so I'm not surprised that in the on-treatment analysis, it was positive for both the primary outcome and heart failure. I would have liked to see the on-treatment analysis for colchicine to be positive. And Massimo, I was as well ideologically very convinced of colchicine, and would have loved more than anything to talk about it as being a class 1 indication in the guidelines after our trial.
The last point.
Question.
Yes, the last point, the last concern I have is related to the effect of COVID pandemic, but was already mentioned by my co-discussant. So I'm not so sure that really, although the COVID pandemic was not so important in the result, also because I read something regarding also the potential efficacy of colchicine that were reduced in your trial for the prevention of pericarditis. Also, the efficacy of spironolactone was positive, but not as reported in other trials. So, to me, I really think that the pandemic has some effect on the trial results. In any case, I think your trial is very important because we need now an additional trial, but so it is very, very difficult to build big trials with this drug. To me, the anti-inflammatory therapy is a new pillar that should be considered in cardiovascular medicine, should be evaluated better. I saw there are ongoing trials, but sometimes even the very expensive drugs with the biological agent that are very expensive. So I really see the risk as a clinician that's working in the national care system, where also the pharmacoeconomy is very important for us, that we are losing a very cheap option if we don't design a very careful trial. And because it is really a pity to lose a very potential powerful and cheap option and to go to additional drugs that are very expensive, considering that at the end of the story, at least one thing was positive in your trial, the reassurance regarding the safety of the drug. That is not enough, but it's something that is important. So thank you for your consideration.
Giovanna, if I may, I'd like to address those issues because, as you know, during the development of new drugs or the development of a new indication for an old drug, phase 3 trials are preceded by phase 2 dose-finding studies in the appropriate target population by selecting an appropriate surrogate endpoint for dose finding. Now, my question is to all the discussants and to Sanjit is, are there adequate phase 2 studies using, I don't know, CRP as the primary biochemical endpoint to say that 0.5 milligram in patients with cardiovascular disease, to say that 0.5 milligram given once daily is the optimal dose to produce a desirable effect in that particular clinical setting?
If I can jump in, very well taken point. Thank you for this question. The big problem is this: the very difficult. Just to the best of my knowledge, we don't have this trial, and the idea is just even in pericarditis to work more on dosing finding, to consider lower doses of colchicine that could be very efficacious because the drug concentrates in neutrophils. So we don't need to have a huge drug that only has the risk to produce side effects. Your point is very well taken. So we made the trial without having a strong hypothesis to suggest the appropriate dosing for the patients. But the problem is essentially is that there are no sponsors supporting our research. So it's very, very difficult to develop this, but it is what should be done in the future if you want to be very serious, consider this option.
Just to have a question that we leave for after this discussion. If you, Massimo, can then summarize to us the effects, the biological effects of colchicine, because I think you are very good in doing this. But first, we finish the round regarding the opportunity to have strong phase 2 trials. Sanjit.
Yeah, no, absolutely. We did not have that work. We also don't know in terms of renal dysfunction how that interplays. So if the creatinine clearance is 45, and what is the impact for colchicine? So, and you can see even within our trial, we started with a higher dose, went to lower dose. I think the one thing we do know is colchicine has a low therapeutic index. And so the higher dose, very quickly, you run into GI side effects. And so finding the optimal dose is incredibly important. And I think that the right way, especially if this was a new drug, would have been to do phase 2 trials and have, 3, 4, 5 doses. Look at a biomarker, look at the tolerability, and then choose 1 or 2 doses to move forward.
François?
Yes, I agree with these comments. Probably it's difficult to try higher doses because of the safety. As you said, the meta-analysis supports the good safety profile, which remains a very important point because it was suggested that it could lead to more non-cardiovascular mortality. It's not the case, so it's a very important point. Regarding lower doses, it could be interesting because we know that in lower weights or in elderlies, it could be enough. And when we consider the use regarding not pericarditis, but other indications such as gout, for instance, our colleagues are using lower and lower doses. But as we want to consider prolonged treatment, probably we could test lower doses, as was mentioned before, because of storage in neutrophils.
François, even your statement that in your meta-analysis there was good evidence of safety, this is true for your meta-analysis of 6 trials in about 22,000 patients. But Sanjit may comment on his meta-analysis in 9 trials in over 30,000 patients, where there is a statistically significant increase of hospitalization due to the GI problems, which requires balancing number needed to treat with number needed to harm.
Yes, an important point. We have to probably check lower doses with a good safety profile and a good efficacy, as you were mentioning.
Okay,
perhaps another way would be to consider more targeted therapies, perhaps.
What do you have in mind? If I can add another comment on the 2 meta-analyses, you come up with different estimates of the effect size ranging from 12% to 25%. Now, these will translate into completely different number needed to treat, which particularly now that major cardiovascular event rate are in the ballpark of 2 to 3% per annum, would translate into a few hundred patients needed to be treated for 1 year with colchicine to prevent one major vascular event. And we could go from 200 to 400, depending whether the 12% or the 25% effect size is actually the correct one. Sanjit, any comment on this?
Yeah, I think the important thing is, I think meta-analysis often overestimate treatment effects because there's often some degree of publication bias. The fact that Ladoca 1 had issues with randomization is still included and had a 70% reduction in event rates. I'm always conservative. Every trial I've done after a meta-analysis, the effect size tends to be smaller and tighter. So I think as a conservative scientist, I tend to believe a smaller effect size as being it's kind of regression to the mean. And most interventions in medicine have fairly modest effect sizes. We don't see 30, 40, 50% reductions in cardiovascular events, probably not since, the early ISIS days, looking at aspirin and streptokinase and acute MI, or statins per se. But in even the more recent statin trials or lipid trials, the effect sizes are much more modest. And that's why it's challenging to do trials. And that's why you may need trials of 20,000 patients to be statistically significant in modern, cardiology.
May I ask to the audience, because your trial challenges essentially the use of colchicine in acute coronary syndrome, but at present the evidence for chronic coronary syndrome is still positive, even based on a few trials. So would you change your practice, because the European guidelines suggest the use of colchicine for the prevention of MACE in the patient with ischemic heart disease? So also in the US, FDA also approved the use of colchicine for secondary prevention of MACE. So in my view, at present, probably we can stay with colchicine but low dose, no more than 0.5 milligram in patient with chronic coronary syndrome. It is an option, very cheap option to test. And on the other side, probably we have to design new trials, bigger trials in the patient with acute coronary syndrome to test essentially if the drug can work in the patient in the setting of the acute coronary syndrome. But those findings is very important, because if we don't have a precise those findings study, the risk is really to not to have a meaningful trial and meaningful study hypothesis.
Okay. Can I make a stop asking to you to answer some of the questions that we have from our audience that are in the chat? One question is the following one. We see Dr. Peter Libby, so we would like to ask to Dr. Peter Libby to his thoughts on the use of colchicine. Peter, would you like to answer to this question? If yes, Lindsay, please unmute Dr. Libby. Ciao.
Hi, thank you. Thank you for inviting me. Sanjit, first of all, congratulations. The study was immaculately conducted, given the circumstances of the pandemic. And I don't know if you recall, but in September of 2020, you guys asked me to write to the CIHR because that was when I think the Ladoca 2 came out, and there was thought maybe they should suspend funding. And I wrote an impassioned letter, of which I have a copy in front of me, saying, the benefits of these agents need to be weighed against the reductions in host defenses, and why large randomized trials are needed, particularly the CLEAR Oasis 9 was what you called it then, not CLEAR Synergy. I believe this trial is even more important after the publication of the recent Ladoca 2 trial. I hope I had a little part in defending your trial when it was at one of those crossroads. Every trial that I've been involved with has had a near-death experience. And it sounds like yours was no different. So what I'm doing now, because we have a clouded picture and I'm trying to present a balance when I present, which actually I will do this afternoon to our immunology graduate students, present a balanced picture. And what I say is that people who meet the entry criteria of Lodoco-2 and Colcott, I would not hesitate to use colchicine if I felt that they needed additional anti-inflammatory therapy. So we're fortunate to have other anti-inflammatory treatments that are under investigation. I see Wolfgang Koenig online. There are probably others who are investigators in the Zeus trial. Hermes and Artemis are looking at ziltivekimab, which is an anti-IL-6 antibody, which we hope will avoid some of the impairment in host defenses that we saw in the trial with canakinumab, which targets IL-1 beta, which is upstream. So, what I say when I'm giving talks about this is we still need to find the sweet spot where we can optimize an anti-inflammatory therapy that's selective for atherosclerotic events and that doesn't lead to an undue impairment in host defenses. Now, I think what we learned from CANTOS really can help us mitigate some of the infectious risk because we know who is prone to get infection. We know what kind of infections they are. They're standard viral and bacterial infections are not weird and wonderful opportunistic infections. But still, I think we need to continue the search. And I think that your trial, in addition to those of the others, are very important milestones as we find our way on this path to finding that sweet spot. Now, let me say, there's going to be an editorial accompanying the two meta-analyses, but we already know that, let me just channel for a moment on Jean-Claude Tardif, who points to the inversion in deaths in the CLEAR Synergy trial compared with other ACS trials. So I wonder if you could comment, I don't think that's come up yet. I wonder if you could comment on that issue.
So inversion of non-CV deaths. So non-CV deaths was lower with colchicine than placebo. And I think the explanation is pretty simple from my perspective, is the evidence that colchicine increased non-CV death was very weak. The p-value was 0.06. It's a relatively small number of events, probably a chance finding. And I think one of the other things is we very carefully measured serious infection prospectively with the concern that it could increase serious infection, and it did not. So I think colchicine is a relatively safe drug with regards to infection and host defenses, while in Colcott it increased pneumonia, but that didn't happen in Lodoco too. So I think there's a clear explanation there. And I think one of the things that's interesting for all these trials is there were both acute and long-term trials. So Massimo said we shouldn't treat acute, maybe, and we should treat chronic. And what's hard for me is when we looked, when does an acute patient turn into a chronic patient? Is it at 6 months? Is it a year? Is it 18 months? And when we look at our curves, our Kaplan-Meier curves, and do landmark analysis, if you look at a year, there's no treatment effect for our chronic CAD population in our trial beyond a year. And usually you'd expect a bigger treatment effect acutely, and then maybe in chronic less so. And so I am left scratching my heads because I think this separation of acute versus chronic works when the trials are 30 days or a year, but doesn't work as well when you have trials of 5 years. And perhaps we do need to do individual patient data analysis where we put all the trials together. And so we can actually look at landmark analysis based on time, because our patients from 1 to 5 years are chronic, and then the first year are probably more acute.
Great. And just one other comment with respect to safety. It's wonderful to see the meta-analyses reassuring us about safety, but remember that there's a huge experiment in the Mediterranean area with FMF, where people have for decades, since the pioneering work of Anthony Fauci's work in the use of colchicine for treating familial Mediterranean fever. And we have a huge safety record, generally at higher doses than were used in the low-dose colchicine for cardiovascular. So it really does appear to be a safe drug.
May I ask to Professor
Peter, Peter, can I take your brain to answer a previous question? If you were to design a phase 2 dose-finding study of colchicine, what would you select as the biochemical or functional endpoint to assess its potential efficacy for phase 3 trials?
Well, with Giovanna online, one would first reach for C-reactive protein, measure the high sensitivity assay, because that we know is validated, and we know that colchicine has an effect in general on
modest effect.
CRP. Yeah,
a modest effect. It was
right.
30% reduction in clear.
Okay. But Peter, there are a lot of questions about CRP. If high sensitivity CRP could be the correct marker to select a patient. So take the advantage to answer to all the questions of our audience too that are in the chat. Go ahead.
Well, you know, in CANTOS and in ZEUS, as an entry criteria, on the background of full standard of care therapy, including high-dose statins, which does lower CRP, we specified as an entry criterion greater than median CRP to try and enrich for inflammation, which was not done, to my knowledge, in any of these trials. But I would say if we had to pick a biomarker today, we might pick IL-6. Back when you, Giovanna, your pioneering work in Rome, and Paul Ricker and his work in Boston were evaluating CRP as a biomarker of inflammation in cardiovascular context. The assays for IL-6 were not standardized, and it was not really, even though 22 years ago, Paul reported relationship with events prospectively, say in women's health and later in physicians' health, and that's been widely replicated, the assays were not really standard. I think with the pandemic, one of the spin-offs of the pandemic is that IL-6 measurements became pretty routine in many medical centers around the world. So we might go with IL-6 rather than CRP, but I would use both if I were designing a phase 2 program.
But you know, in CLEAR-Oasis 9, there was only a 30% reduction in CRP. Would this be a degree of reduction that would translate into a clinical benefit?
Right. Well, in CANTOS, we saw 36%, and actually in SELECT, there's a 39% reduction in CRP. That is with the GLP-1 receptor agonist. And I see Wolfgang Koenig is on the line, and he's one of the real experts in biomarkers. It'd be cool to get his input about that.
Lindsay, please, could you unmute Professor Koenig? Thank you. Lindsay, could you unmute Professor Koenig?
Okay, can you hear me now? Maybe.
Yes.
Okay.
Yes.
No, thank you very much. I mean, it's a great discussion on a very timely topic, a controversial topic. So it's really a pleasure for me to participate. Now, two things. First is I'm glad that Peter brought up the safety issue, because actually, in my mind, this was the major information for me from the CLEAR Synergy and also from the CONVINCE study, because in earlier discussions, at least that I had with my colleagues, always the major argument was it's not safe enough. We have this excess in non-cardiovascular death in the Ladoco 2, etc. And this obviously has not been replicated in these two more recent trials. In terms of selecting the appropriate target, I think Peter is perfectly right. If it comes to anti-cytokine therapy and the selective inhibition of the inflammasome, the NLRP3, CRP and IL-6 are probably very much appropriate. I'm not that sure if that also applies to colchicine, because the spectrum, the anti-inflammatory spectrum, is larger. Look, for example, at the colchicine also affects the neutrophil activity and a couple of other things. We're doing right now proteomic studies and see whether we get some more information on what's going on after colchicine therapy. So this would be probably the major biomarkers, and Peter mentioned already ZEUS, and CRP has been selected for that trial in CANTOS. We also had the C-reactive protein, and it worked very well in a study, in a phase 2 study with siltevecumab, the rescue, there was a much, much higher reduction in C-reactive protein compared to the initial data in CANTOS. Namely, I think about 80% or something like that in rescue. So much more effective. A final point from my side, I agree with some of the comments Massimo made, because I have some concerns with regard to the design and of the CLEAR Synergy study. I think you already mentioned the issue that you recruited during the COVID-19 period that may have had some effect. I think you even stopped the trial for some time in between. Recruitment phase was relatively slow, and you increased your patients that initially were only patients with STEMI, if I'm correct, by large. I think it's mentioned large non-STEMI. So how large they were, I don't know. Somewhere in the supplement, I found an ejection fraction of 45%, but I've never seen in the whole trial any global left ventricular measure. And two issues I'm wondering about is, first, in terms of a lack of effect, is the pericarditis. I mean, the literature is fairly strong and consistent in terms of effects of on pericarditis by colchicine. That's one point. I don't know why that didn't show a clear-cut effect. And the other one was in the 2x2 trial. I mean, you had STEMIs, you had large infarcts, and still the spironolactone didn't show a strong effect, as we have seen in other trials, except for TopCat, for example. So coming back to the issue of compliance during this problematic period of COVID-19, and I think these things should be discussed. I also do agree that we need additional trials, because the situation right now is still controversial and conflicting.
So I'll address the comments around the pandemic. So I think, like everything, recruitment shut down for a period of time, probably a period of 6 months during the pandemic when everything was locked down. There was no recruitment. And then recruitment gradually picked up as things reopened. And then maximal recruitment occurred post-pandemic. So as when things were fully opened up, our recruitment was maximal at that point and greater than pre-pandemic levels. I think in terms of, I think the important is, despite being an academic trial, less than 1% lost to follow-up. Compliance, we had discontinue rates around 25%, 26%, but that's not, it's slightly higher than some of the other trials, but not greatly so. And I think that the pericarditis was very uncommon. And I think it's important to know that the vast majority, and Massimo can speak to it, we don't have really trials of post-MI pericarditis, right? These were mostly de novo pericarditis where we have most of the evidence. And we don't really have good evidence in patients post-MI prophylactically putting them on colchicine, preventing pericarditis. It makes sense that it would prevent pericarditis, but the event rates are very small, and so I don't think I would make too much of it. But at the end of the day, I agree that is still a peculiar finding. But certainly if we even look at the 4,000 patients post-pandemic, there's no treatment effect. And so for me, that still is an unanswered question. And so I think it's easy to blame the pandemic, but as someone who's really looked in the data, I don't believe that that's solely the case of why this trial is different.
Okay, Massimo.
Yes, may I ask to the audience, because we are at the end, going back to the clinical practice. So would you use in your patient with a chronic coronary syndrome a low-dose colchicine, and would you nowadays, after the CLEAR trial, and would you use high sensitivity CRP to guide maybe the decision of to treat this patient with colchicine or not?
Sanjit, what is your answer?
I am no longer using colchicine, unfortunately, and I was the biggest user of colchicine in my institution, so I have some doubts. And where I may still use it in patients who, we have nothing else to offer, multiple recurrent events based on maybe a small treatment effect, but I'm no longer routinely treating patients with CAD, whether chronic or acute, with colchicine.
François? Are you using the colchicine in patients with chronic coronary artery disease? And are you measuring high sensitivity CRP? Filippo, are you using colchicine in patients with chronic coronary artery disease? We have our editor-in-chief joining us. In the right moment, you can answer this very, very difficult question.
The final question.
The final question.
That was a mistake from me to join at the right time, at the wrong time, because the question is so difficult. But let's be positive as usual. This is science. Science is a continuous progress. We learn from our mistakes. At the present stage, I would say that the effect of colchicine, also based on meta-analysis, is there, but small, which means that in principle, because the side effects are not so severe, there's no excess mortality, non-cardiovascular mortality, which was something we feared initially. The meta-analysis showed that the effect is mild or medium, depending on the meta-analysis. The safety profile is reasonably good. I tend to agree with Sanjit. We have to decide patient by patient. If in spite of optimal treatment, the patients tend to have recurrent events, I think colchicine is something to consider seriously. Work in progress. For the first time, we have an anti-inflammatory treatment which is clinically actionable. It's the first time. So let's enjoy this first opportunity. The effect is mild. I mean, it's nothing really window shattering, but it's useful, in particular in some patients. The challenge is to stimulate our researchers, younger researchers in particular, to go for something new. It's not the end of the long trajectory of anti-inflammatory treatments. We have a first victory. Let's go for something more powerful hopefully in the near future.
Okay, on this word of wisdom, I would say we have to come to a close. And I greatly enjoyed this discussion. Thank you very much to Sanjit, François, and Massimo, but also to Peter and Wolfgang for interesting questions and comments. I hope the rest of the audience who connected with us also enjoyed this European Heart Journal dialogue, and I look forward to seeing you in the near future. Perhaps, Filippo, you may want to announce the next dialogue.
Yes, Carlo. Thank you also from my side. Thank you, Giovanna and Carlo, and really thank our guest for this very, very interesting dialogue. I've missed part of the dialogue, but as you know, it's posted in YouTube. Now we have an archive of more than 40 dialogues in YouTube with the most prominent cardiologists in the world. So I will have a chance to see this dialogue in YouTube. So thank you for your participation. And next dialogue, don't forget, the next dialogue will be on the last Thursday in May at 17 Central European Time. Will be a Thursday. And the next dialogue will be
We lost you.
Thanks.
Will be on Filippo.
I believe 24th of April.
Okay. But we
And
don't know the
with you. Same thing. Any comment? No. Okay. If not, thank you very much for your participation, and we'll meet again in 1 month.
Thank you all.
Okay. Thank you. Thank you to all of you.
Right, thank you very much.